come to the end of this session, but we have very interesting session coming up where I think that Professor Samia will take over. Dr. Younglin Bay will join us here. And Thierry is not alone.
And Dr. Mauro. And we'll ask Dr. Mauro Picardo, Dr. Somesh Gupta, and Dr. Younglin Bay to join us, please. Well, we are having a very exciting session about the systemic therapy of vitiligo and how we might have some cases that are difficult and how can we choose. And we want to discuss with our experts as well as you for the few cases that we are going to see. First of all, Dr. Hamzawi will give us a short introduction about systemic therapy for vitiligo.
Just get into the session. So, our AV guys, so can you pull up the systemic therapy section from my folder, please? So we're going to talk about an overview of all the different systemic options we can use for vitiligo. Then we're going to talk about cases that you can apply that to, but also challenge us because you got ideas that we may not have. So, are you able to find that presentation? Oh. Okay. Yeah, it's on the folder there. There you go, right there. Okay, there you go. Okay. Oh, wait. Okay. Great. Conflict of interest that you should be aware of. So we know that there's immune and pigmentary targets. I'm going to give you 2 review papers from our group. Tasneem Muhammad worked on these, and I worked with her on that. So this is one on systemic therapies in vitiligo, another one on a review of systemic and targeted therapies. Now, when we talk about OMP, azathioprine, narrowband phototherapy, JAK inhibitors, one of the challenges we have is that it's hard to compare because the outcome measures are different. Some people use pigmentation, some people use a percent pigmentation, some people use VASI, some people use VES. But then how do you compare all these studies? You also have different types of patients. Some people have segmental, some people have non-segmental, some people have unstable. And then you don't know what the natural course of the disease is. So when you say you made an intervention that changed the course and you don't have a control arm, it's hard to compare. We also don't have definitions of disease severity, stability, and the sample sizes are very, very small. So that's why the outcomes work that we're doing is so critical. So I wanted to kind of quickly go through the systemic treatments, and I figured maybe you can take a picture of this, but we're going to talk about all these options, and you've heard some discussions, but I'm not going to go over the mechanism of action. You can take a picture, but we'll cover that. But these are just some of the therapies that we'll talk about in the next few minutes. And these are some upcoming treatments: afamanotide, statins we're not using too much, ginkgo biloba. And then these are some of the upcoming treatments: ruxolitinib, tofacitinib. There's also ritlecitinib and provocitinib, which are also coming down the pipeline. Now, I wanted to talk to you about what we know. And those of you who know the literature well, correct me if I'm wrong, but these are how many people are in these studies. For the OMP studies, the measure was disease stability. What is the measure of disease stability? We don't agree upon that. And then you've got 40 patients, 22 patients, 71 patients. Not all of them are randomized controls, and they're from 16 to 24 weeks. Azathioprine, only a few randomized control trials, 55 patients in those studies, 24 weeks. Methotrexate, cyclosporine, minocycline, alpha MSH. Again, you're talking about 100 patients at most, different endpoints, different timelines. So how do you compare these? And then you've got the upcoming trials. Tofacitinib, I believe, has got a trial coming up, but they've been very small. Ritlecitinib just was completed and did a very large phase 2 trial with 364 patients, pharmaceutical industry sponsored, but that is probably going to be the gold standard. And then we have some of these other options that are coming up. I want to emphasize the aprelma study, which was a negative study, is probably one of the best ones done, and it showed it didn't work. So when we get up here and say, well, this worked for my patient, this worked for my patient, realize it may not work for your patient because these standards have differed. And here's a diagram we put together of the mechanism of action. You can pull that out of the article, but in the next few slides, I just talk about the different targets within the intracellular area that's occurring within the keratinocytes, within lymphocytes, corticosteroids, you know about those. There's lots you have to monitor for those medications. AZA, MMP, similar intranuclear process using de novo purine synthesis. And then the JAK inhibitors hit the JAK receptors, but then the different JAK inhibitors have different effects and different bindings to different receptors. Some 1, 2, 3, some are TYK receptor inhibitors. And we'll talk about those throughout this meeting. And again, you have to monitor. And the point of showing you all these mechanisms of actions and all these areas to monitor isn't so much that you have to know about this after this talk. You'll learn about it throughout the meeting. But these are not simple medications. They have a toxicity. And as we get into cyclosporine, which is another medication, when you use it, JAK inhibitors, and then the systemic JAK inhibitors, and then medications you don't get yet, alpha MSH, is showing a lot of promise, but we don't have the data. Then drug failure. When we get into the various drugs, realize that some medications don't work, even though they worked in you, and that depends on the inclusion criteria. Lastly, I thought this was one of the best papers of the year, and Samia's paper, so Samia, I'm going to take your thunder. But early intervention, aggressively done, does it stop progression? And Samia's thesis is, and her group, is that if you don't treat aggressively in the beginning, you don't make a difference. I would agree with her, but somebody can easily flip the data and show that that's not the case because we don't have the natural course, natural history. But these are some of the ideas of early intervention to make a difference, randomized controlled trials, and realize that these upcoming studies, they don't just help you learn if this drug is working. Look at the study design and you can see how well the older drugs work. And so this is a presentation with lots of references, so I'm going to go through here just a couple of seconds. So if you want to take a picture of this, there's 67 references in these slides. But I think it's important that you pull these references. And then they're in the papers I presented earlier. I also added a few more references. But in summary, we have very limited options. We have very small numbers of patients in these studies. Given that, we have to have an expert panel and your expertise to make the best decisions. So there we go.
Thank you, El, very much. Now we can, you made us a very nice summary. Can Dr. Bey please present his experience with cyclosporine now? Yes?
Not this one.
Is it underneath your name?
Not in this folder. Thank you for introducing me. My name is Jungmin Bae from the Catholic University of Korea. Spreading vitiligo would be a challenge for all of us. Systemic steroids are frequently used, but there are still many cases where we cannot use steroid. In addition, continuous use of steroid for persistently spreading vitiligo may not be easy, considering various side effects. I would like to share some of my experience to use cyclosporine for active vitiligo. As you all know, cyclosporine is an immunosuppressive drug that binds to calcineurin and reduces phosphatase activity. Inhibition of T cell activity by cyclosporine may contribute to the stabilization of vitiligo. There are a few reports on the use of cyclosporine for active vitiligo. The first one is the case series. 18 patients with progressive vitiligo were enrolled. They took cyclosporine 3 mg per kilogram for 12 weeks. Disease progression was halted in 61%, and 50% showed various degrees of repigmentation. In 2021, a randomized controlled trial was reported. 50 patients with active vitiligo were randomized into two groups. One group took dexamethasone 2.5 mg for 4 months, 2 consequence days weekly, and the other group took cyclosporine 3 mg per kilogram for 4 months. 2 months after completing the 4 months medication, 84% and 84% and 88% of the two groups showed arrest of progression, respectively, showing no statistically significant difference. However, the mean time to arrest of disease was significantly faster in the cyclosporine, 10.9 weeks, as compared to the steroid group, 13.9 weeks. The third study divided 50 patients with stable vitiligo who underwent melanocyte keratinocyte transplantation into two groups. Group A received no post-operative treatment, and Group B took cyclosporine 3 mg per kilogram for the first 3 weeks and 1.5 mg per kilogram for the next 6 weeks. As a result, all patients who took post-operative cyclosporine group showed excellent repigmentation of more than 75%, and it was a remarkably better result compared to the no post-operative treatment group. Now, I would like to share you some of my cases. 29-year-old women visited my clinic with whole body progressive vitiligo. She had experienced side effects when taking systemic steroid previously, so she needed an alternative drug. She started taking cyclosporine 150 mg with narrowband UVB phototherapy twice weekly. 6 months later, the disease progression stopped and more than 75% repigmentation was achieved. Next is a 53-year-old man with active generalized vitiligo. Facial lesions were spreading towards the forehead line and periphery of the face. Because he had diabetes, he did not want to use a systemic steroid, so he started a combination therapy of excimer laser and cyclosporine 200 mg. After 6 months of treatment, you can see that more than 90% of the lesions repigmented. The patient underwent blood tests every 2 months, and no abnormality have been observed yet. Last is 53-year-old woman with segmental vitiligo. At first, she was on prednisolone 20 mg pulse therapy with excimer laser and topical tacrolimus for 3 months, which showed a great improvement. However, it recurred. She restarted taking prednisolone 20 mg pulse therapy for 5 months, which showed improved again. However, it recurred again. So this time she started taking cyclosporine 150 mg for 5 months. She showed excellent response and is currently under maintenance using topical tacrolimus. In conclusion, cyclosporine would be a viable option for the treatment of active vitiligo, including non-segmental vitiligo and segmental vitiligo. It is particularly useful for patients with steroid side effect, diabetic patients, and patients requiring long-term steroid use. However, more controlled studies are needed. Before the presentation ending, I would like to invite you all the Korea Derma, which will be held in June 2023 in Seoul, Korea. You will be able to experience the various aspects of K-beauty, and innovative technology of Korean aesthetic dermatology. Thank you for your attention.
So, Bei, you are introducing cyclosporine to be an alternative to corticosteroids, oral mini-pulse steroid, or, I mean, can you start with it, or you only think of it when steroids or oral mini-pulse is contraindicated, or not effective, for example?
In my cases, I don't use systemic steroid. Yeah, I only use cyclosporine.
You don't use oral mini-pulse now. Since when?
I use dexamethasone pulse therapy, but in these cases, I
Yes.
don't use dexamethasone.
Yes, I mean, do you put cyclosporine as a choice that we can take it as a first line, or it's only second line after oral mini-pulse?
My first line therapy is dexamethasone, prednisolone, but in the cases they have some side effect or
Yes.
diabetes, and they don't use steroid.
Yes.
In these cases, I use cyclosporine as a second line.
Actually, many times when we start to prescribe the oral mini-pulse steroid, especially in children, we have lots of concerns. That's why we are looking for an alternative that can be a first choice. Does anyone of the panel have experience with cyclosporine? Please say.
We published one study comparing the both oral mini-pulse with cyclosporine and found OMP has edge over efficacy I was looking at, but still there was no statistical significant difference. But maintenance of repigmentation or maintenance of stability was still better with the OMP rather than cyclosporine. So we prefer using OMP compared to cyclosporine if there are no other conditions like diabetes, hypertension. But still, I mean, that's a broader question we are discussing today. I mean, many years or still, I mean, there are debates going on like we should give aggressive immunosuppressive therapy or we go for the safer phototherapy or other option as a stabilizing agent. So among this is one of the agents, like cyclosporine is again a broad spectrum immunosuppressive acting through that pathway and arresting the damage to the melanocyte by acting as a broader immunosuppressive agent. We expect it to be effective in controlling the disease activity. But question is when to start this cyclosporine or other broad spectrum immunosuppressive agent, as we are moving towards the small molecules, the JAK inhibitors. So probably we need to define the role for these agents.
I think this is a question that needs to be answered. When to stop the stabilizing therapy? Do we have a limit, and should we only state when the disease is stable, or we have to stay for a longer time? This is, I think, a question that we all need to work on it to have an answer for that.
I just wanted to mention the fact that phototherapy after 3 months is an immunosuppressive on the skin. And so if you treat with cyclosporine and phototherapy, and then you conclude that the improvement was from the cyclosporine, unless you're doing a controlled study, that may be an erroneous conclusion. Phototherapy is, in my view, a safer long-term cutaneous immunosuppressant compared to dexamethasone or cyclosporine. We all know that no matter what you use, those CD8 positive T cells are still in the bone marrow, the spleen, in the bloodstream. We have not found a way to remove the bad T cells without killing the good T cells. So we all know that there has to be some type of chronic, constant immunosuppression. So in my view, maintenance phototherapy is a safer route rather than trying to give bursts of cyclosporine or bursts of dexamethasone. Or chronic azathioprine is not something that we use in the United States, or chronic mycophenolate mofetil we don't use either. But perhaps with the new JAK1 inhibitors that I'll be talking about tomorrow, we will find a safer way of long-term immunosuppression that will keep the T cells, the central T cells, from migrating to the skin on a long-term basis. But as you probably know, there's companies working on IL-15 inhibitors, et cetera. And hopefully we will be able to eliminate those T cells permanently. That's the ultimate goal, so that we don't even have to have these debates or discussions.
Anyone of the audience would like to add something about cyclosporine? Yes, Dr. Raisa?
I'm a cyclosporine guy because I work in Vancouver with Vincent Ho, and anyone who knows Vincent Ho, he's a cyclosporine. I mean, because we have a clinic called Cyclosporine Clinic, and this was more than 20 years. So my point, I use cyclosporine a lot in my clinic for psoriasis and other things. But anyone, if I want to choose steroid or cyclosporine to maintain my pigment cell, I would use cyclosporine because I think the safety profile for cyclosporine is very high. Because those who's using cyclosporine, they know. I can tell you, I never had any patients having any major problem with the cyclosporine infused properly. So, but I have so many patients with steroid. Steroid has steroid phobia. Patients, very tough to convince them to take steroid. And at the same time, the morbidity of steroid are way more than cyclosporine. So my point, is there any, I am not aware of anyone who's using cyclosporine as a maintenance for their pigment cell. So, but I think it's worth to have it, I mean, as a trial, I mean, as a cyclosporine low dose to maintain what we have achieved. I think with low dose, I think it's a very safe medication. When you use it in a very high dose in the elderly, this is another issue with the blood pressure or with the renals. But I think we are underusing and underestimating the cyclosporine, and we are overusing and a lot of we using the steroid as a maintenance or as a mini pulse. I just want to hear one of the, I mean, if you commenting about cyclosporine use
And what do you consider, Ahmed, what do you consider low dose? 1 milligram per kilogram for 1 year, 2 years? What would you feel comfortable with in terms of dose and duration of cyclosporine?
I don't know, but I just need some guidance. So I think if we just starting using, we might see some good paper about this. But I think we are underusing cyclosporine. It makes more sense in vitiligo, cyclo, rather than steroid for long-term mini pulse.
I think Dr. Abdullah's got her hand up, and then Dr. Manish over there.
Thank you. So I treat vitiligo a lot, like, you know, so I think we have all been sitting since morning. My take is very different, okay? Now, I say when we see a patient of vitiligo, think psoriasis. I repeat, you see a patient of vitiligo, you think psoriasis. We very confidently tell all our psoriasis patients, you cannot be cured. You need to keep on rotating your drug. You need to be on a combination drug. This is what I counsel my patient now. I say, at this moment, we do not have a cure. You have autoimmune disease, which is going to keep running endlessly. You need to be on some immunosuppressive drug for, we don't know how. So my thought is we keep on rotating our drug. It can be your OMP, it can be your cyclosporine. I'm a fan of methotrexate. I find methotrexate to be very stabilizing. And you can use azathioprine. So as in psoriasis, we have a combination therapy. You know, you combine phototherapy and a molecule, and then you keep a patient on cyclo, acitretin, metho, and you keep rotating or get the biologicals, scafo or something inside. Similarly, in the treatment of vitiligo, we cannot stop the treatment. The autoimmune process is going to keep running forever. Thankfully, a lot of vitiligo patients go into remission much more than psoriasis. A. B. A lot of vitiligo patients need a very low dose of immunosuppressive. They don't need very high dose. I give my patients mostly 7.5 milligram methotrexate once a week, and I can sustain them for a very long time. I mean, so I think that's a thought.
So, I mean, it's really a matter of who's that? Yes, please.
Since we are discussing oral mini pulse and immunosuppression, when we were going to study azathioprine effect, I was surprised that in India, when we went to Drug Controller of India, there was no dermatological approved indication of azathioprine. No, none. So they were saying it is off-label, there is no indication. Somehow they agreed to give permission to try. So what Dr. Amit Pandya has said, we also did a study on photochemotherapy in progressive vitiligo versus non-progressive vitiligo. And I agree that after some time, narrowband also has an immunosuppressive effect. So, partly disagreeing with Dr. Munish Paul, psoriasis recurrences are very frequent. Long-term recurrences are also there. Vitiligo, it does recur, but these episodes are far off in the sense of, for several years they may be having a residual static disease and then there may be aggravation, reactivation. So it is slightly different. Cyclosporine in India, if I am correct, Dr. Asit Mittal from Udaipur Medical College, he is using cyclosporine a lot. The problem with cyclosporine, I find one, that when you are using a low dose, 1 to 3 milligram per kg, the nephrotoxicity may not occur in short term, but nephrotoxicity is an issue. Hypertension may happen much later. So, coming back to what to do. For rapidly progressive, definitely oral mini pulse, but then you can't use for a long time. So you have to rotate, but rotation among the immunosuppressant, by my experience, azathioprine has idiosyncratic reaction in any individual, but if it is accepted in any individual, long-term side effects are not there as compared to cyclosporine or maybe other drugs. So you have to individualize the patient. The patient may not come for narrowband chamber. So you can't give narrowband therapy to everybody. It is not available. So it is not a formula like anti-tubercular therapy for 6 months you are giving 4 drugs. You have to individualize and you have to use all these agents, sometime agent A or sometime agent B or C or D.
Yes, that's what I mean. Changing the treatment will help to reduce the side effects. So we'll proceed to the next case.
Can I just point one point?
Yes.
Dr. Venkat here?
Yes. Yeah, yes.
Here. Ma'am, I'm here.
Yes, okay. You're welcome.
Here.
Yes.
Okay. She's still all right. Now, there is Munish and Dr. Vinod Kaitan have been comparing psoriasis and vitiligo. But there is one crucial difference they didn't point out. In psoriasis, when you use these drugs, you get remission very quickly. The psoriasis lesions disappear within 2 weeks of methotrexate or cyclosporine. That doesn't happen in vitiligo. It takes months before some pigmentation appears, and it takes even longer for significant pigmentation to appear. I agree they have to be rotated, combination has to be done. All that is correct. But this is a very important difference when we give immunosuppressives to vitiligo patients.
All right, thank you. So it is actually choosing the proper systemic treatment and how long to use it and which the best for each one really needs tailoring. And I think it's something that makes all us worried. I will show you some of the cases that I have a trick, or maybe they were not just straightforward ones, and I would need your advice, please.
Are we open for?
It was a 30-year-old male. He came presenting that he has white, itchy facial patches of 4-month duration, and that he received treatment for those by phototherapy, narrowband UVB, that he had exacerbation of the itching and of the lesions. Well, the patient has erythematous areas, and I see depigmentation below the hairline there. The Wood's light showed frank vitiligo, but the distribution was very suggestive of actinic induction. That this distribution is not just facial vitiligo, but it's there on the forehead, on the eyebrows, and in the upper cheeks. That's why actually I thought about it is solar induced or photosensitive vitiligo. So what do you think?
Well, it could be photo-induced, but also 20% of vitiligo patients have atopic dermatitis. Another significant percentage have contact dermatitis.
Yes.
And another significant have seborrheic dermatitis. And so
Yeah.
it's possible that he has a combination of two conditions.
This patient, when I asked him, he's working as an engineer and he goes to areas on the mountain and is exposed so much to the sun. And when I examined the rest of the body, I found also over the hands, those were the only two areas involved, the arms and the face by that distribution. Actually, I did some the blood tests for anti-nuclear antibody. It was positive. But the other lupus tests were negative, and the hepatitis B, because hepatitis C was one of the factors that cause photosensitivity in our country, it was also negative. Actually, what do you think for treatment for such a case?
So can you just go back to the...
Actually, I'm a big fan of phototherapy, and even patients with face lesions, I insist that they can take, and we start to increase the dose gradually, but he had the history of exacerbation with narrowband UVB.
So just a couple of small points. So one, Amit and I were just talking about, could he have lupus, systemic lupus?
Yes.
Secondly, could he have HIV? Because we've seen this pattern in early HIV
HIV was
diagnosis.
negative too.
HIV, okay.
Yeah.
Can you go back to the clinical images?
Yes.
Is it possible that he's using hair color and PPD causing depigmentation?
No, this is his natural hair color. Yes.
Yeah, it looks too black, but yeah,
yes,
maybe
it is too black, but this is his hair color. And the lesions were of very short duration. There was confetti very clear at the arms. Anyhow, and I did not give phototherapy, of course, but I give oral mini-pulse, hydroxychloroquine, physical sunscreen, and ginkgo biloba. So it is the systemic treatment. It does not have an oral mini-pulse, but the antimalarial will help to improve the photosensitivity condition. What happened that the patient has improved after he came every month. This was after the first month, and this was after 2 months of treatment without phototherapy at all. It was only the systemic treatment that he received. And then I told him, next time I will see you in 2 months. So when he came this time, this is the hands after the treatment. When he came this time, there was an exacerbation, evident exacerbation. So when I went with history with him, he told me, I stopped itching, I don't have any burning. So he started to go back to the work and to be exposed to the sun, although he was wearing the sunscreen. So it became evident that the sun was behind, exposure to the sun was behind this rash. This was the first visit in each site, when he improved, and then he got worse again after the sun exposure. These are the 3 times or the 3 visits.
You could try the minimal erythema dose to sunlight. MED you could try to determine in him to find if it is very much lowered.
Excuse me? I haven't...
You could try to determine the minimal erythema dose
yes.
to sunlight, to the narrowband UVB to find out what is the range he is in. We know what an average person is going to have, and you may find out if it is very low in his case.
But this case already had sessions of narrowband UVB, and it was harmful.
Yeah, that's what I'm telling. You can try to do a minimal erythema dose to that over the back.
You want to give him lower doses?
No, you can find out whether he has a tendency to burn or develop erythema at a very low dose or not.
Photo testing on the back.
Yes.
Photo testing on the back.
Photo testing, yes, yes. Yes, on his back, yes, all right. No, actually, I did not do a photo testing because I believe that it was sun-induced, and when he improved, and then when he got worse, I got sure that he needs total protection from the sun. Yes, please.
Yes, Samia, why didn't you perform cutaneous biopsy with histology and IFD in order to confirm or not to confirm lupus?
That he is not lupus, but he doesn't have...
Even if
yes.
you do not know what is exactly the problem,
yeah.
you do a biopsy with IFD.
Yes, I can do that. I mean,
Yes.
this case, I mean, I'm following him up. I told him you can return back to the treatment and get away from the sun, and I'll see you next month. So,
Sir,
yes.
Sorry, Samia, sorry. I think photo testing is worth. Why not to give UVA? He might be UVB photosensitive. Then you have an option of UVA. I think photo testing to identify which wavelength it is very useful, and UVA is a good option.
Yes.
And in these patients who are photosensitive, I have stopped phototherapy until it went away, the photosensitivity.
Yes.
And then I have started them at a lower dose, 100 millijoules, but I give them 200 milligrams of ibuprofen 2 hours before phototherapy. And this is something Dr. Hamzavi taught me.
Yes.
And that prevents the photosensitivity, and then you can increase by 5 to 10% rather than the standard 15% per treatment. And then I've had my patients be able to tolerate that as long as I've confirmed histologically that they do not have lupus.
Yes, you can see this is my next case. The second case was this gentleman. He had vitiligo on the face for...
Dr. Sami, just 1 second. I had a suggestion. Would you consider adding topical tacrolimus to his face? Because we do see very good repigmentation with tacrolimus, and it could help in reducing his need for oral immunosuppression.
Yes, of course, it can be considered. I mean, we have all the options. What happened that he responded very well to being away from the sun and wearing sun protection, so I did not even need to use any other topicals.
Yeah, but that would be a lot of modification in his lifestyle to, ask him to avoid the sun when his job involves sun exposure.
Yes.
Right, so it might make sense to try a few more things.
Yes, to use a different topical treatment. Yes, of course. Yes.
Just to say one word, there is another therapy that can be proposed. It's hydroxychloroquine.
Is this Dr. Azidi?
Yes.
Yes, how are you?
I think we can propose hydroxychloroquine in those patients who are... she did it. Yeah, okay, I arrived too late. But those patients, from what I see, you can do everything you want. They will still be photosensitive.
Yeah.
Unfortunately, and they progress very quickly. They progress usually very, very quickly.
This is the other face of the coin. This patient has vitiligo on the face for years, and he came telling me that I want to get a solution. And actually, when I heard that he has been there, he has been like that for 8 years, and he said that whenever I try to get phototherapy, I get burns. And I told him the solution for you will be depigmentation, because he started to develop lesions on his hands. But he refused, he totally refused. I will not do depigmentation. That's why I thought in this case that we might start by low dose narrowband UVB. And actually I did that with low escalation and using ibuprofen, and this was the result. So this case is the other side of the coin. I mean, these are two different cases. One of them is really harmed by the sun, but this case has responded to phototherapy by the way you suggested, sir, that we did low dose and low escalation.
Congratulations. That's a great. One of the things I do when they walk into my office, like he is on the left, is I carefully examine their forehead and look at the hundreds of vellus hairs to see if they're black. And if all of his vellus hairs are white, I still tell him we can try phototherapy, but his prognosis will not be as good.
Yes, that's it.
Yeah, the face is wonderful, but even the bigger achievement was the acral areas repigmentation. Yes. And the complete repigmentation of the finger.
The fingers, even the hands, because they were recent lesions. He used to have the face lesions for years, but the hand lesions were only a few months.
So that's and that brings me to a question I would love to ask my Indian audience. We talked earlier today, this afternoon, about marginal repigmentation, especially over the knuckles. If you notice his right hand, he has a 1.5 centimeter lesion which did not completely repigment. What is it possible somebody has done a study in which you determine how many millimeters does the margin close in a type 2 skin, type 4 skin versus type 6 skin? If we have not done that study, somebody should, because that will help us give a prognosis. If you remember the presentation from Calicut, he showed very good repigmentation on the hands, but not the lesions that were 2 centimeters or more in diameter, only the lesions that were 1 centimeter or less. So I wonder, what is the migration ability of melanocytes and correlated with skin type from the margins?
There is probably another thing that you should think of. I am quite sure that age may play a role, and there is melanosenescence. So it might be easier in younger than in elderly. And this is another point. Did you hear me? No, I think the age of the patients is very important to take into account. Not only the phototype, but probably that you repigment much more easier when you're young than when you're, and there is melanosenescence, I think, also to take into account. Maybe Mauro can answer us.
I also think the duration of the lesion, when it's shorter, they repigment faster, for sure. So, another case.
So me, in that last case, how long did it take for him to repigment to that degree? And it was only narrow band, no OMP?
You mean this case, the last one?
Yep.
It took around 4 months.
4 months.
Yeah.
And so he's a rapid repigmenter.
Yes.
And then did you have
I like the ibuprofen. Really made a difference. Now you are using it now for all non-photo adapters.
Right. And no orals, just the phototherapy.
No. He received only because he was not active. I only received.
Yeah. Good for you.
Yeah. This is the question that raises a debate. If the patient of vitiligo comes with one small lesion like that, dating of 2 weeks, 4 weeks, or 1 month or 3 months, what should we do? Shall we give topical or systemic treatment?
So acral areas, when they are involved, has to be treated with more aggressively than the extent of involvement, because the problem with acral area is that if these lesions get established, as you said, that if they progress and the tips are involved, then nothing is going to work. Your medical treatment will not work, your surgical treatment will not work. So I often consider the acral lesions appearing in a young person as an emergency.
Yes.
And it has to be treated with unreasonable aggression, which may sound unreasonable. And this is an indication for mini pulse therapy and cyclosporine or JAK inhibitors, even though the patient has only few lesions present and few are emerging.
Samia, I think aggressive topical clobetasol is worth to do in early, because I find clobetasol in acral is the only thing that works in early. So I have abrupted so many acral just with clobetasol early. This is maybe, you can call it mini pulse or whatever, like in topical clobetasol.
They might respond well to topical, but the idea is what is the incidence of recurrence of such cases? And does systemic treatment will reduce the recurrence or not? And this is an issue that, especially that we are now having a lot of systemic tools that can be given, if given early, they might make a total difference in the future of the patient.
I think, at least in the United States, the vast majority of patients who come in like this would not get oral mini pulse, would not get cyclosporine, would not get azathioprine. They would likely get a topical and eczema laser or some type of phototherapy. I think part of it has to do with the stigma of the disease. If you're from a society where the stigma of the disease is going to affect the ability to get married, the ability to get a job, reflect on your moral status, reflect on your karma, there may be a difference in your willingness to have aggressive therapy. In the United States, we have many cultures, we have many different types of people, and so we have to have a conversation with that person. And some of my Indian patients do see this as an emergency. and they do want extremely aggressive therapy, but I would say the majority of us in America would not treat with systemic therapy as a first treatment.
You're probably right. It's the same in France, I think. But if I come to the point of Summers, if you consider that in vitiligo you have resident memory T cells, and it's just the beginning, well, I'm not sure that we should not treat very aggressively. And even if we don't do it, because legal issues, this is the main reason we don't do it in Europe. But if I was in a country where I can do it, I think I will discuss clearly with the patient the advantages and the disadvantages, and I will do it.
Well, I'm going to push back a little bit on that, Khaled, because we don't know how many of these patients will progress. We assume it's the case, but you don't have data saying out of 30, 40, 100 patients we followed over 2, 3, 4, 5 years. And so now you're taking something that's uncertain, and you're adding a definite risk. So again, I would lean to not do that. But again, I understand the subcultures and the differences. But the data is clear. We don't have natural course data on this particular entity.
May I add some comment? In my experience, those cases, a few acral lesions, early lesions at that time, I think that I consider intraregional steroid injection. And topical steroid. At that time, sometimes very good response.
With phototherapy?
Well, actually, those cases were the base of our study. Those are one of some of the cases that we did, the study that we give systemic therapy for early cases. And actually, we had very good results, very rapid response, and a lower rate of recurrence. We did not did a control. We did not bring some people with localized lesions and give only topicals. We did not compare that. And maybe because we felt that we are doing very good job with those, so we did not take a control them. But I find that everyone are asking for doing a control, and now we are working on that. But those people, very good response, and some of them are now being followed up for 7 years without recurrence. The incidence of recurrence is around 32%, which is in relation to other reports were around 60. So we have achieved a good, I mean, we can all work or do a big project that we can all work on the early localized lesion and see. Even the risk, it's not that big risk. We only give the systemic therapy for 6 months, or maybe maximum we will give for a year. And usually they are not harmed. So long they are not of the vulnerable groups, they are not children. I think we can try that, Yes.
Just a biological point of view, to obtain migration of melanocyte, it needs collagen 4. And in acral lesion, you have a deficiency of collagen because there is not any dermis. So I think the study of clinical migration of melanocyte is not sufficient. It needs to have histological study because with clinical it is not sufficient. So I think that the problem of acral vitiligo can be resolved after the increasing of collagen 4 in acral lesion. I think it is not with stimulating of pigmentation, because in a culture dish, if you have not collagen 4, you have not migration of melanocyte.
Yes, thank you. These are the cases, and I'm presenting. Those 3 did not have recurrence for now. This for 4 years, or 5 years, and this was the paper that we published. And this is the acral case with only a small lesion that it really took time for it to respond. It took almost 6 months of oral mini-pulse steroid till he had complete repigmentation, and he is still coming to me till now, and he is okay. He did not develop any more lesions. And this is another case with 2 lesions. We found that the recurrence is more in bilateral cases. The patients, if they have two on both sides, the recurrence rate is higher. And also for segmental vitiligo, I don't know if you give systemic treatment for early segmental, because this is also a form of a debate. Does it control the disease? Should we continue systemic treatment for a while or not? I don't know what you think about the segmental. If a patient comes with early segmental vitiligo, should we give systemic treatment or we only give topicals?
I think there is only one study for this. It's Jungmin. Yeah. You should discuss this. It's your retrospective study on segmental vitiligo and systemic therapy.
Yes, it works very well. The patients get repigment quickly. They do not take systemic treatment for a long time, and they get controlled without recurrence.
I do treat with systemic treatment if they have confetti-like lesions, hypochromic borders, Kebner phenomenon, yes, where they shave,
when you feel shaving. They are active.
If they have those,
yes,
then I do. Otherwise,
but
if they don't have those signs,
yes, but if we could not control the segmental vitiligo early, it will turn into poliosis, and we will need to do surgery.
No, that's
Although
true.
Surgery is a good solution for segmental, but still we can save them, the operations.
Samia?
Yes?
I'm here.
Yes.
You know that we have published that
the zoster, the herpes zoster?
Zoster virus is responsible for segmental vitiligo. And I did a study, of course, for the treatment. And when you treat with valacyclovir or acyclovir, at least during the first months, we have complete.
This is very interesting, yeah, right? Because
yes,
when did vitiligo develop? Probably the virus was not there at the same time, but you found the virus.
Sure.
Yes.
But we found the virus in actively spread in segmental vitiligo,
yes,
not in old one,
yes,
or stable one.
Another issue about the segmental, I think the most important issue about the segmental, yes, if there is a leukotrichia, please be less aggressive with any other medications and think of surgery.
Surgical.
I know,
yes,
because some people, they just look segmental without looking to the leukotrichia. And leukotrichia, see it with a dermoscopy. Sometimes clinical is not evident,
yes,
but once I see leukotrichia, I always think this is a surgical case sooner or later.
Yes, that's right.
We have also an improvement in leukotrichia when you start antiviral therapy very, very soon.
Oh, that's fine. Does anyone want to comment about the herpes zoster issue?
The distribution is not dermatomal at all.
I invite you to assist to this discussion and to the conference of Yvon Gauthier tomorrow, and you will.
I'll become a believer.
Yes, herpes zoster, but there is involvement of not sensory ganglia, but there is an involvement of sympathetic following the artery without pain, and we have had the surprise to find in 3 early cases with electron microscopy the virus in the cytoplasm of segmental vitiligo, of melanocyte. Pardon.
So it may be a factor in a small proportion of the patients, because we do get children, very young children with segmental vitiligo who never had chicken pox, and children never get herpes zoster, and yet they do get segmental vitiligo. And like Dr. Amit Pandya mentioned, many a times it is quasi-dermatomal, somewhat dermatomal, not exactly dermatomal. So it may be one of the factors in some of the patients.
Quick question for the audience as well as the panel. Anybody using submicrobial doses of minocycline that I think the vendor described before, but anybody using that as steroid sparing at all?
No. Dr. Srinivas.
I have been using minocycline for quite some time, and I find that it is a very good alternative to giving more of the more toxic immunosuppressive drugs. And of late, I'm even trying the topical minocycline, because we have got a topical minocycline, and I have found that in 1 or 2 cases, there is some amount of pigmentation. Not too early to comment on that, but I find that it seems to be working. So I would go for that. And may I just comment regarding that small lesion on the finger where he said, I agree with Somesh that in India we have to treat it aggressively, but what we usually do is we try to follow up. So we can give some antioxidants, buy some time, see whether it is increasing or not, and if we find it is increasing, then we can become more aggressive rather than immediately going for an aggressive treatment. Time is a very, very important thing in dermatology. Time sets many things right which we cannot.
So at least we agree that we can use the early treatment when the lesions will be irreversible if you are late. Yes. Well, this case actually is a resistant case. He was he's a gentleman, 40 years old, with vitiligo starting then for 6 months. We started, and he had lots of body lesions that with black hairs that were expected to respond well to phototherapy, and that's what he removed actually, narrowband UVB. But this case has a special condition that he has multiple sclerosis, and he is receiving the diethyl fumarate. When he came to me with that, I searched everything. Does we have contraindication with phototherapy? Does this treatment exacerbate the lesions or not? He had a history of receiving interferon therapy for his disease, but he was not controlled with that. He's only controlled by the diethyl fumarate. And the incidence of vitiligo occurred after he started this therapy. I don't know if anyone have experience with multiple sclerosis and vitiligo. Because, yes, please.
Yeah, so we did a study, I think maybe 7 or 8 years ago, and we looked at it, and we had a cohort of neurotoxic, neuroimmune diseases such as multiple sclerosis, myasthenia gravis, Guillain-Barré.
Yeah.
And those 3 diseases were much higher than the general population. Yeah. So, and I've got about 2 or 3 patients with multiple sclerosis who progressed right when they were diagnosed with multiple sclerosis. Their vitiligo progressed too.
Yes. He does not respond to phototherapy, and I'm worried which systemic treatment I would give him. Because he is, I will show you the pictures later on.
But
he has increased.
They get steroids all the time, so
yes, exacerbation with even no sign of stabilization of the lesions. I even thought of JAK inhibitors. I found in the literature that some of them, I think it was Photosensitive, had demyelinating effect as a complication. So I was worried. I did not give it to him. I don't know. We agreed that I'm going to get his case here to listen what we all suggest that we can give for his treatment.
Well, first of all, we're just scratching on the surface of comorbidities and vitiligo. We are learning so much more about comorbidities. I mean, Khalid Ezzeddine has been publishing on that quite a bit lately. So I think we're going to know more and more about comorbidities as time goes on. But what I would do is I would really partner with this person's neurologist and offer the treatments that you standard would use.
He said okay for oral minipulse, but the patient did not respond. He took oral minipulse with no response at all.
And phototherapy.
Yes, he said okay, but he refused to give him immune suppressant. And when I asked for methotrexate, he said, no, don't give methotrexate. Now I don't know what to give him. We stopped phototherapy now for a month, and he is still progressing.
Can I offer something here? Excuse me, here. We are forgetting the role of stress that is aggravating the disease.
Yeah.
So we should find ways to combat the stress. He has got a major illness. That major illness is going to have a telling effect on his vitiligo. So combating his stress, giving him some anxiolytic might help him a lot.
Yes.
But
Right,
just, Samia, if I understand right,
Yes.
did he develop his vitiligo or did he worsen his vitiligo after receiving interferon?
No. Well, during interferon, he had no vitiligo lesions. He developed it when he started the diethyl fumarate, or maybe 3 or 4 months after. But I found that diethyl fumarate can be used for treatment of vitiligo. There are some reports that it can be effective in vitiligo treatment.
Honestly, I would do exactly the same than Amit. I would not take any decision without consulting the neurologist, because I think multiple sclerosis is a very serious disease. And I'm not saying vitiligo is not serious, but it's not life-threatening normally. And I don't know. I will discuss with them for any decision.
All right, thank you. This is my last case. And this is the first announcement about the VIS 2024 in Cairo. And you'll all be welcome to attend with us. I know it's just 2 years away, but we are working since maybe a few months ago to make it a nice meeting like that. Now, Dr. Hamzawi will show us his cases.
Well, I think we're done.
Yeah,
okay. I mean, the audience wants to eat, and I don't want to be between them and dinner.
All right.
Okay. So dinner is there, but we're going to give you cases. Let them have cases. Okay. So I have some images, and hopefully I can kind of use those. So let's see if our wonderful AV team is still awake, or they want to go for dinner. So we're going to go to... This is a dedicated group of people. Okay, so the third one down, please. Okay, so this is a case. He's a 38-year-old Black American. There was a biopsy done, and I'll go over the biopsy with you. But he's been diagnosed with vitiligo. He's failed phototherapy, tacrolimus, topical steroids, as well as OMP for 3 months with almost no improvement. And this is the lesions that we see here. And I think there's another image. Yep, he's got these 2 lesions. So 3 times a week with phototherapy, topical tacrolimus, OMP also used. And the scalp is the most bothersome area to him. So any thoughts or any suggestions? So the biopsy was done and did not show hypopigmented MF, but it did show a few melanocytes were present, so it was not devoid of melanocytes. And then we did a shave that went across the entire area, but that's a good thought.
It doesn't look like a vitiligo case here. Yeah. It doesn't look like classic vitiligo. It doesn't fit into any known patterns of vitiligo. So there is, it seems that surface change, some dryness, some scaling. There is a condition known as hypopigmenting dermatitis. And I don't know if the rest of the body is involved or not in this case.
Yeah, it was just the torso, and his hands were clear, feet were clear, just the torso and the scalp.
This is something that somebody called hypochromic vitiligo, and fortunately changed his mind, and now I think it's be called macular
seborrheic macular hypomelanosis. This is not a form of vitiligo, and so I have seen these patients. They're usually African American, but I do have one South Indian, Hindustani patient who has this also. And it's in a seborrheic distribution, and with the Woods lamp, you do not see the red fluorescence in the center like you see with progressive macular hypomelanosis. Also, progressive macular hypomelanosis is not above the neck. So I don't really know what it is. I think there must be some infectious organism involved, but I don't think this is vitiligo.
Probably deeper, you're right, probably deeper than just the surface of the skin. And what we have done, I have a few patients, but I'm not saying that it's with who we tried itraconazole for I think 3 months plus phototherapy, and we obtained it in some patients, not in all, some results. And I agree, I was wrong when I was saying hypopigmented vitiligo, and you're right when we described the entity, but at least we said at that time that this is different than the classical vitiligo. And you don't have really depigmentation. In some patients you might have depigmentation, but it's always in the seborrheic areas, which is a good clinical tool to differentiate with hypopigmented MF, which usually is not restricted to, and here you see, when you look at them, it seems that it's around the hairs that everything is happening. Probably there is something with mycosis. I don't know how to say it, but it's really difficult cases.
Yeah. Well, that's what we did. And I was hoping that you would have this interchange because the category, so what's the new name?
Seborrheic macular hypomelanosis.
Yeah, so that's, so we published this and then we're going to recategorize it based upon this conversation, but that's what we thought it was. I still don't have him repigmented. He's still unfortunately disfigured. I'm sorry.
Where's the Woods light?
Woods lamp was indeterminate, and I didn't get a picture of that.
To see it, then it's very important. What's characteristic here is that, as Dr. Khalid is saying, they're not around the hair follicles, but they are just small rounded areas. I think there are several petrospora that produce kind of PV-like lesions, and it could be this or seborrheic dermatitis, but we don't know about the history of itching or scaliness, dermoscopic. I mean, more looking through these lesions clinically could help us more. As audience looking here.
We have treated them for seborrheic dermatitis with tacrolimus, pimecrolimus, desonide, hydrocortisone, phototherapy, even some of these with oral mini pulse dexamethasone combined with phototherapy, ketoconazole, topical antifungals, sodium sulfacetamide. We have treated them like standard seborrheic dermatitis without much success. The only thing that's worked, maybe 50% improvement for me, is aggressive phototherapy combined with oral mini pulse dexamethasone. But still, it's only about a 50% improvement.
Yes, Dr. Mysore?
So there are some cases which you see on the back in India very commonly. Is the post-inflammatory hypopigmentation following pityriasis versicolor. That seems to persist for a long time. I don't know whether that coincides with what Dr. Amit Pandey is saying. But we have also seen these cases on leg, which is not the seborrheic distribution. So in some cases, as Khalid mentioned, it's somewhat similar to hypopigmented mycosis fungoides, which we see not uncommonly in India. And they're pretty resistant to treatment, and they don't often respond at all. Now here, there is some work in India by Dr. Ratnam Attili. I think we are very familiar with him. He has been following these kind of cases for a very long time, and some of these cases he calls vitiligoid hypopigmentation. And he suggested there is a spectrum, vitiligo, vitiligoid hypopigmentation, lichens closer to heterotrophicus. He thinks there is a spectrum. Some of them resembling LSA, some of them not resembling vitiligo but still hyperpigmentation. He has also published this with histopathology and has been working for quite some time, and I think there is some truth in what he says, that it actually shows a spectrum of hyperpigmentation. The amount of hyperpigmentation may vary, but still they may be part of a spectrum of.
Thank you for that. I think that's a good spectral conversation because there's something unique about this pattern. And good. Okay, bhuk lag rahi hai. So I guess what we'll do is we'll call the program at this point. But that was a nice mimicker, a differential diagnosis. Thanks so much for joining us, and I hope that we have lots of wonderful conversations like that. But now it's time for dinner. So enjoy. Thank you, Samia, for organizing the program.